Yo creo que estamos en un momento de transición, entonces digamos que lo más importante es saber cómo ese gap lo podemos saltar de un lado al otro. Hay varias cosas, yo trabajo en Estados Unidos, pero también tengo un rol con la OPS y tengo experiencia de trabajar con muchos países y tener grandes experiencias con lo que se llama ahora clínicos, farmacéuticas, y voy a dar un ejemplo, voy a hablar un poquito de eso al respecto. Ojalá, y me da lástima porque es que hay mucha gente que me está escribiendo en el WhatsApp, que está escuchando, que son clínicos farmacéuticos colombianos que están trabajando en los hospitales y dicen, yo estoy acá, y yo sí, voy a decir que ustedes están acá. Entonces, hay más de lo que pensamos. Entonces, lo primero que hay que hacer es que hay más de lo que creemos, y segundo, para mí el problema no es de conocimiento, para mí el problema es de empoderamiento. Entonces, el primer paso que yo invito a los prescriptores en todos los países del mundo es que los dejemos de llamar químicos farmacéuticos y los empecemos a llamar clínicos farmacéutas. Y esto es algo que yo aprendí de los farmacéutas, que cuando ya trabajan al nivel de hospital, digamos que cómo yo los llamamos a ellos tiene que cambiar. El momento de cambiar la forma como los llamamos, cambia totalmente la forma como no solamente ellos se comportan, sino que te da un rol en el hospital. Entonces, empezando a llamarlos por clínicos farmacéuticos, el siguiente paso es, hay una responsabilidad de nosotros en proa de capacitación. Ahora, para mí el problema no es de conocimiento porque yo siempre estoy impresionado. Yo ya no vivo sin un farmacéutico al lado porque ellos saben más que yo. El antibiograma en mi hospital no lo hago yo, lo hace mi clínica farmacéutica. La persona que está hoy en día dando las recomendaciones es ella, no soy yo. Ahora, tomó un tiempo en el que nos encontráramos, generamos una relación como pareja, porque tampoco tenemos que ir a hacer juntos todo el tiempo, pero toma un tiempo para uno entenderse, saber cuál es tu rol y cuál es el mío, en qué eres tú fuerte y en qué soy yo fuerte, y el otro es, si no hubo capacitación de infectología, ser uno como ese mentor, si es doble trabajo, pero vale la pena, porque pues en estos momentos no hay capacitación. Llegará un punto en el que la demanda para que empecemos a hacer capacitación y las universidades o los hospitales empiecen a decir, vamos a tener residencias en infectología el año extra. En Estados Unidos, la persona que estudia para farmacia hace los 2 años de farmacia y después hace un año extra de especialización. Se pueden dedicar a hacer administración, se pueden dedicar a farmacia. Todos hacen rotaciones clínicas, by the way. Y este año simplemente hacen un año extra en el que se dedican a solamente a ser infectólogos. Entonces, en PROA en los Estados Unidos, en los hospitales donde se hace mucho PROA, ya uno de los requerimientos para contratar es que hayan hecho ese año extra. Y el compromiso de nosotras es que si tienes ya un PROA consolidado, generas una rotación especial para generar más, porque hay deficiencia de clínicos farmacéuticas con especialización en infectología. Entonces, es un paso en el que estamos empezando, pero entonces yo digo, la responsabilidad de nosotros como clínicos y después entrenarlos para que ya se genere la demanda y ya se genere esta demanda de este entrenamiento oficial para generar esos farmacéuticos clínicos en infectología. Y poco a poco, yo estoy segura que esto se ve prontitico en Colombia y en los otros países, ya se ha visto en muchos otros.
Vamos con una pregunta para el doctor Franco y después le damos la cara al público. Doctor, tenemos diferentes organigramas en los cuales está articulado el PROA en nuestro país. Basado en su experiencia, pros y contras de dónde debería estar el PROA o dónde está ubicado el PROA, dirección médica o dirección de calidad y seguridad del paciente. ¿Cuáles son los pros, los contras?
Gracias. Esa pregunta es muy interesante porque tradicionalmente nuestros hospitales ubican calidad y el Comité de Control de Infecciones debajo de la dirección médica. Usualmente, digo yo, cuando en la atención en salud en el 99% de los casos, de pronto un poquito más, 99.5%, las cosas salen bien. Pero cuando salen mal, el paciente tiene o un evento adverso, o una infección, o se murió, por errores de la atención. Y eso carga a la dirección médica. Entonces no es infrecuente que desde la dirección médica se quiera hacer lo del gato, ¿cierto? Que es cubrir esa vaina, meterla por debajo y no sacarla a la luz. Cuando no sale a la luz, no se estudia, no se investiga qué pasó, no se aprende, no hay mejora. Desde el año 2000, 14, nosotros en Imbanaco pusimos a la dirección de calidad par de la dirección médica y a todo lo que tiene que ver con prevención y control de infecciones y PROA en el lado de calidad. De tal manera que ahora, si eso funciona de esa manera, pues se van a hacer los errores visibles y se va a dar la oportunidad de poder aprender de esos errores para que cada vez la atención sea mejor. Eso es una práctica frecuente en países de altos ingresos y países desarrollados, que hay un par del director médico, es el director de calidad, y pues con eso nosotros tenemos la tranquilidad de que los errores que se cometan, porque van a suceder, somos humanos atendiendo humanos y los humanos cometemos errores, se van a hacer visibles y se va a poder aprender de esos errores. De tal manera que la respuesta es esa, Cristian. Para mí, en un organigrama, calidad y todo lo que tiene que ver con infecciones debería estar por fuera de la dirección médica como un par de la dirección médica.
Muchísimas gracias, doctor. Adelante con la pregunta del público.
Bueno, yo tengo una pregunta para la doctora Paola. Antes de eso, felicitar al compañero farmacéutico. Ese tipo de automotivación y autodidáctica es la que necesitamos cada vez más en PROA, sobre todo en nuestra región de México hacia abajo. Y hacer hincapié en lo que mencionaba la doctora Paola y el doctor Wilfrido lo recordaban hace algunos minutos, en la parte de fortalecer las habilidades en Diagnostic Stewardship. Y cito a la doctora Barbara Trotner, que entre otras cosas recomiendo exhaustivamente leer a la doctora Trotner, y es en atacar al médico prescriptor antes de que tenga la intención o si se quiere, la tentación de prescribir el antibiótico, ¿sí? Sabemos que yo siempre llamo que el Diagnostic Stewardship es como uno de los dos super amigos en PROA, pero esta fase preanalítica es la más importante, al menos empezando los PROA que apenas están comenzando. Yo he tenido como ese efecto eureka, atacando esa parte preanalítica, urocultivo cuando sí, cuando no, cultivo de esputo cuando sí, cuando no, otras pruebas cuando sí, cuando no. Eso es lo que más rápidamente va a generar resultados en PROA. Ahora sí, la pregunta, además del trabajo de Morenzi Potvin de la 5D, que me parece genial, hay una sexta D, que la escuché por primera vez en la ID Week del año pasado, que es el disposal, el desecho de los antimicrobianos. Ahora que cada vez está más en boga el concepto de One Health, de una salud, sabemos todo el impacto que tiene a nivel ambiental la enfermera que desecha por el lavamanos el resto de antibiótico o antimicrobiano que no se administró y otras prácticas en las instituciones que pues en nuestra región son frecuentes. En tu experiencia, ¿qué estamos haciendo con el disposal? ¿Qué están haciendo en Estados Unidos? ¿Cuáles son tus recomendaciones y cuál es el alcance del PROA en esa sexta D? Gracias.
En teoría, gracias. Primero que todo, Bárbara Trauner, yo trabajo con ella, mis estudios de catéter urinario y de asintomática son de ella, y en las 5 días de urinarios son de Bárbara, son de la editorial de ella. Así es que se la recomiendo porque ella es la persona que más publica en estos momentos en catéter, en infecciones asociadas por catéter y en cómo leer bacteriología asintomática. En cuanto a desechos, en realidad desechos en nuestras instituciones tiene que ver con lo que se llama environmental y con farmacias. Y en realidad, cuando estamos hablando de desechos, nosotros simplemente somos comunicadores. O sea, porque cuando estamos hablando de desechos de antimicrobianos, cuando estamos hablando de desechos en general en One Health. Entonces, si hablamos a nivel simplemente de hospital, en mi hospital, eso simplemente hay un perfil muy claro y lo único que uno es el rol de la farmacia, que no se quede en la farmacia, sino la farmacia salga a los pisos. Y volvemos a la misma historia. El mundo está pidiendo que la farmacia salga de la farmacia y se comunique con el mundo exterior. Y esa es parte del clínico farmacéutico. Él va, viene, comunica y se encarga de que todo esté pasando, asociado con control de infecciones, asociado con las partes de ambiental. Ahora, como OPS, como OMS, el One Health tiene que ver y básicamente se está tratando en 3 estructuras. La parte de disposal se está empezando a trabajar y hay piñitos en eso. Hubo un grant en el que se está trabajando sobre eso, sobre todo en el área veterinaria, digamos la que está trabajando más en eso, cómo se hace la distribución o el disposal final de los antimicrobianos, sobre todo en ganadería, en apicultura y ese tipo de cosas. En los hospitales yo diría que está mucho más organizado. Entonces yo le veo mucho menos problema, y está en los ministerios cuando van a hacer Probablemente tú sabes mejor en eso, en seguridad y en calidad del paciente, que eso es parte de acreditación y parte de un hospital en el que están midiendo y están viendo cómo se hacen sus desechos en un hospital. El problema grave es en las farmacias, en la educación al paciente de qué hacer cuando le sobran los medicamentos, y veterinaria, que es la que más cantidad de antimicrobianos y desechos vas a ver, sobre todo en aguas, que es la que más preocupa. En Brasil hubo una reunión y se estaba hablando de ese tema, se está empezando a trabajar en esa, pero digamos que esa es la tercera de los 3 focos grandes, y el otro es agricultura. Pero digamos que esa es como el mayor impulso. El de los 5 años que yo vi fue en salud humana, después viene la salud animal y tercera agricultura, y esa es la que más trabajo tiene que ver con desechos.
Bueno, y vamos con una última pregunta para el doctor Wilfrido Coronel. Doctor, la doctora Ana María Monsalve, la pediatra que nos apoya en el PROA pediátrico en Clínica Imbanaco, que es fantástica y próximamente va a ser colega suyo, infectóloga, ha venido trabajando con nosotros en el PROA y conocíamos niveles de ansiedad en cuidado intensivo adultos, pero la verdad es que estamos descubriendo nuevos miedos y niveles de ansiedad en cuidado intensivo pediátrico y neonatal, sobre todo neonatal. ¿Cómo lidiar con la ansiedad de los pediatras neonatólogos en la unidad de cuidado intensivo? ¿Qué consejos nos da?
Pues yo le agregaría otra cosa a la ansiedad, y es que la mayoría de los pediatras en cuidado intensivo y los neonatólogos, con todo el respeto, uno de los medicamentos para su ansiedad son el uso de antibióticos. Entonces los antibióticos ya no son antibacterianos, o sea, para matar bacterias, sino igualmente ansiolíticos, vasopresores, todo, o sea, igualmente hasta antipiréticos, ¿no? Entonces, lo que nosotros hemos hecho es realmente darle como un respaldo a los intensivistas, es decir, miren, siéntense seguros de que nosotros estamos aquí y lo estamos apoyando para que sacar a este paciente adelante. ¿De qué manera? Mostrándole todo lo que es de evidencia. Lo que hacemos nosotros es, primero, mostrarle algunas cosas a las cuales ellos no tienen tanta competencia. O sea, porque igualmente uno no se mete donde yo no tengo mi competencia. Yo no soy ahorita para yo manejar un ventilador y decirle, póngale el pic en cuanto, bájele la frecuencia tanto. No, sino que le doy la seguridad en el cual esa competencia que él no está manejando, aquí estoy yo para ayudarle el respaldo. Esa competencia de decirle, mire, este bicho se comporta de esta manera, está mostrando este perfil, el paciente está mostrando esto, mire que los biomarcadores son tal cosa, yo voy a estar aquí, usted tiene 24 horas con mi teléfono, nosotros estamos comunicados con microbiología 24 horas, todo lo que salga inmediatamente me comunico con usted y listo. Y ahí vamos, y le vamos enseñando, lo importante es siempre discutir con el paciente y el médico. Nosotros no vemos los pacientes solo sin el intensivista. Siempre lo discutimos con el intensivista. ¿Cómo está viendo usted al paciente? O sea, en este momento este paciente tiene probablemente un aumento de los parámetros ventilatorios, pero ¿para usted qué cree que es? Es un evento asociado al ventilador, no es una neumonía porque no cumple con esto, esto y esto, los parámetros son esto, el biomarcador es negativo. Entonces eso lo tenemos ahí siempre. Y eso creo que ha bajado un poco a la hora de que realmente ellos coloquen un antibiótico. Y lo otro es, después que usted lo coloque, listo, en 24 horas, 48 horas reevaluamos, volvemos a ver al paciente, miren los resultados, miren que no creció esto, miren que le podemos ir escalando. Entonces todo eso es lo que hace que de pronto el intensivista se sienta un poco más seguro. Así bajamos un poco la ansiedad, que ellos sientan que nosotros estamos allí, no que nos miren como, claro, él pone eso y se va, y el que queda con el paciente somos nosotros, pero eso es lo que estamos haciendo, tratando siempre lo posible que ellos se sientan seguros con nosotros.
Muchas gracias, doctor. Doctora Villegas, la última pregunta.
El último comentario. Una de las cosas importantes para todos los que hacen PROA, generalmente en Latinoamérica está el infectólogo, que es la sombrilla, siempre lo digo, y hay una persona que es la que hace la vigilancia, mide, va, que depende directamente, y bueno, están los otros grupos, como lo quieras, especialidades. Es muy importante lo que estabas diciendo. Cuando uno quiere liderar un PROA, generar confianza, tienes que hacer reuniones o revistas con la persona de proa, que sepan que está totalmente alineada contigo, porque nosotros generalmente tenemos médicos generales, no son infectólogos los que directamente del proa, ellos hacen interconsultas, pero no es proa, como hemos hablado, y eso le da mucha confianza a que si el del proa se está desplazando a decirle al médico, mira, porque este antibiótico y escuchar mejor esto, y si no, llama al infectólogo, el que sea, eso tiene una validez. Entonces, lo que ustedes hacen de pasar revistas es la única forma de generar, pienso yo, escuela. Y hay que generar escuela porque eso significa confianza. Y para eso, los del PROA tienen que destinar la mayor parte de su tiempo a educar, revisar, sentarse con los médicos, hacer consensos, estar pendientes, de poder estar uno a uno con ellos. Eso uno no hace una guía y la impone, eso nadie la va a guiar. Y para pediatría es un reto mayor porque hay menos positividad en los cultivos, básicamente los Ns de los HUNET son tan chiquitos que uno no puede concluir muchas veces para hacer las guías, entonces lo que estás haciendo es perfecto. Y frente a los químicos hay que incorporarlo más. Nosotros tenemos un grupo muy importante en Imbanaco, de los cuales algunos están en comunicación permanente con el PROA cuando detectan algo. Si hay que educar en mecanismos de resistencia, hay que escoger si todos en general, y hay algunos que quieran dedicarse al PROA, definitivamente, todavía no es tan usual, pero hay que irlos trayendo en la clínica. Pero cuando dimos las primeras charlas de mecanismos de resistencia, nos miraban con unos ojos así porque eso les da la tranquilidad de por qué nosotros cambiamos antibióticos, por qué nosotros este antibiótico no es adecuado. Si no saben eso, va a ser muy difícil hacer la interacción. Entonces eso es lo que quería decir.
Bueno, finalmente agradecerle a nuestros conferencistas por sus magníficas presentaciones, a ustedes por acompañarnos en este importante bloque donde hemos recorrido la importancia de los programas de optimización de los antimicrobianos, los desafíos, las barreras y las oportunidades que tenemos para avanzar en este campo que es esencial en nuestra práctica clínica. Muchas gracias a todos. Dejamos a Juan Carlos con un anuncio.
Gracias, Joana. Sí, en 5 minuticos comenzamos ya con nuestro simposio satélite patrocinado por Pfizer de casos clínicos desafiantes en el uso de ceftazina y Bactam con el doctor Brian Shields. Entonces, nuestro patrocinador les ofrece unos lunchbox que están afuera, entonces las personas que quieran pueden salir y de una vez entrar con su lunchbox y en 5 minuticos comenzamos con la charla del doctor Shields. 5 minuticos, por favor. Gracias. Buenas tardes a todos. Los invitamos a tomar asiento. Ya en un par de minutos, en 2 minutos, comenzamos con nuestro simposio satélite patrocinado por Pfizer. 2 minutos, por favor. No, dejemos eso un momentico, sí. Los invitamos a ingresar, los invitamos a tomar asiento. Ya en breves segundos comenzamos con nuestro simposio satélite. Le recordamos a nuestra audiencia en línea, para todos aquellos que están en Zoom, que para la charla del Dr. Shields pueden utilizar la herramienta de traducción en vivo que encuentran en la parte inferior de su navegador de Zoom. A toda la audiencia que está en línea, no olviden utilizar la herramienta de traducción simultánea que encuentran en la parte inferior. También para sus preguntas, para el Dr. Shields, las pueden hacer en la sección de preguntas y respuestas.
Sí, bueno, buenas tardes. Espero que con el almuercito suban la glicemia y que realmente nos aprovechen esta intervención del doctor Shields, que yo creo que ya no necesita más introducción. Creo que nos ha dado unos puntos espectaculares frente al tratamiento que debemos de hacer con los pacientes, y vamos a ilustrar eso hoy con unos casos clínicos que él nos trae. Así que espero que sean muy participativos. Aquí tenemos al doctor Germán Esparza, que nos va a ayudar en toda la parte microbiológica y diagnóstica. Así que, Dr. Shields, welcome again. It's a pleasure to have you. You want that one? The one is on, and this one too? You want to stay there?
Yeah.
Okay. Downstairs.
All right, good afternoon. I wanted to thank the organizers again for the opportunity to be here, and for the sponsor for this symposium, Pfizer, for the opportunity to talk to you about one of my absolute favorite topics, and how can we manage these very challenging, difficult cases to improve the outcomes of our patients. I might have to find the clicker. Okay. And I promise no gross surgical pictures during lunch. These will all be challenging cases, but appropriate for the lunchtime hour. So my goal today is to talk to you about how we can optimize the use of ceftazidime avibactam in the year 2024. We've learned a lot about this antibiotic in the last 10 years, and I'll tell you some of the important lessons we've learned through trials and tribulations as we move forward. But specifically, there's three main topics that I'm going to cover over the next 45 to 50 minutes or so. Number one, what is the risk factors for KPC treatment failure and resistance? And what can we do to overcome the possible failures or emergence of resistance with ceftazidime avibactam? And how important is PK/PD in treating a common infection like pneumonia? Are we able to get the drug to the site of infection for things like pneumonia and CNS infections or central nervous system infections? Secondly, is ceftazidime avibactam as effective as alternatives for multi-drug resistant Pseudomonas? This is an organism that we see very commonly, and I'm going to share with you some unpublished preliminary data that you'll be some of the first to see about the comparative effectiveness between ceftazidime avibactam and ceftolozane tazobactam. And then I know a common question that many of us have is how can we optimize the use of ceftazidime avibactam plus aztreonam for NDM? And we now have some new insights with the development of aztreonam avibactam and what the right exposures might look like for your patients. So before we talk about where we are in 2024, let me take you back to where we've been, because I think it tells a very important story. In the year 2013, the CDC in the United States released this report, the antibiotic resistant threats in the United States. And what you can see was happening at that time is the situation was quite dire. In fact, rates of CRE were increasing on every continent in the globe, and our available treatment options were horrendous. We were treating patients with combinations of colistin and tigecycline and aminoglycosides. And unfortunately, we didn't have good dosing guidance of how to appropriately dose these antibiotics. Because none of them individually were all that effective, we were using combinations and cocktails of antibiotics. And we had to just accept the adverse events and collateral damage that came from using these very toxic medications. And not surprisingly, unfortunately, the patient outcomes were not good. If you look across observational studies during this time period, you'll see mortality rates of 30 to 50%. Nearly half of the patients with severe invasive CRE infections were dying because we couldn't appropriately treat them. So let's contrast that to where we are now in the present day. Well, the CDC has updated their report, and that's encouraging, and we have new epidemiological data. And at least in North America, where I practice, the rates of CRE are decreasing. In Latin America, it appears they may still be increasing. But what the most important change is what you see in the top of your slide here is our treatment options have now completely changed. We don't use any of the prior options that I just mentioned to you if you have access to antibiotics like ceftazidime avibactam. Not only were antibiotics like this developed to treat multi-drug resistant gram-negative infections specifically, unlike any of the prior antibiotics we talked about, but generally speaking, these are very safe, tolerated medications we can give to patients. And because of that, we can largely use monotherapy for many patients with CRE infections. We have avoided adverse events, and we have standardized dosing. And most importantly is that number in green that you see on your screen is mortality rates are now significantly decreased, something like 10 to 20%, which likely represents the underlying diseases of severely ill patients that we'll never get to zero, but this is a pretty good place to be. Now, things were going good, of course, until COVID-19, and then many of our hospitals rerouted a lot of the resources that we had dedicated to both the surveillance and management of multi-drug resistant gram-negative infections. This is a report again put out by the CDC that compared rates of multi-drug resistant gram-negative infections and other resistant pathogens in the year 2019 compared to 2020. And you can see at the top that rates of all of the resistant threats increased, including CRE. In the early COVID days, we tended to overuse antibiotics. We rerouted surveillance systems, so we didn't know how common these infections were. And certainly many of our stewardship teams were disassembled to route towards COVID-19 management. So we've come a long ways, and I think it's important to recognize, particularly being in Latin America, that KPC is still the most common CRE that we see in the globe. And this is a report that is now somewhat outdated that shows epidemiological data from 2012 to 2017. But you can see based on each distribution, whether it's Latin America, Europe, or globally, KPC still accounts for the majority of carbapenemase enzymes identified in the world. This is certainly true work done by Juan Carlos and colleagues that showed us that KPC is prevalent all across Latin America, as are other metallo-beta-lactamase enzymes that we'll cover during the course of the presentation today. So what does our guidance documents and our most recent recommendations tell us we should be doing when we encounter something like KPC? Well, the IDSA suggests that we have now 3 viable treatment options, ceftazidime avibactam being one of those. Other antibiotics that aren't yet available in many parts of your region, meropenem, babribactam, and imipenem, relebactam, are also equally preferred. But importantly, in red, we don't really have comparative effectiveness data to know if one of these particular antibiotics is better than another. When should we be strategizing using one over the other if you have access to many of them? But they do recommend that combination therapy is generally not recommended. And what the literature suggests about using combination therapy for something like KPC is you see no difference in patient outcomes, but you see more toxicity in the setting of combination therapy. Now, AskMed or the European guidelines have also developed recommendations for what to do for CRE infections, and specifically now we're talking about KPC. They say both ceftazidime, avibactam, and meropenem, babribactam are active. If in vitro, those should be what you use. And again, they also don't recommend combination therapy, and we can talk about some of the management questions that come about with that in a moment. Okay, so the goal today is to talk about ceftazidime avibactam. And I think about the development of this antibiotic, and I can assure you we will never see another antibiotic develop the same way that ceftazidime avibactam was. The reason for that is this particular antibiotic went through 7 phase 3 randomized clinical trials. This really showed the limitations of the clinical development pathway we had to bring new antibiotics to the market. We didn't need 7 phase 3 randomized clinical trials in the face of increasing rates of resistance. What we needed is this drug available much sooner. But most importantly about those 7 phase 3 clinical trials, almost none of them included patients with CRE infections, which of course we know is the intended use of an antibiotic like ceftazidime avibactam. So importantly, almost everything we've learned about ceftazidime avibactam since it was first approved by the FDA in 2015 has come through real-world evidence studies. And fortunately for us, there have been a ton of real-world evidence studies that have been published, both in Latin America, North America, and globally. And these studies now account for thousands of patients and almost hundreds of studies that have been published that have given us very important insights on how to optimize the use of this antibiotic. The most important message I can leave with you is that when you dig into these observational studies, you'll find when you compare treatment with ceftazidime avibactam to what we did historically to treat KPC infections, there is no denying that using ceftazidime avibactam saved the lives of patients by decreasing mortality. And these are studies done in the United States as well as parts of Europe. And all show the same message. Mortality rates are significantly decreased compared to prior best available therapy. Now, what's also important about these studies is almost all of the patients enrolled across the studies I'm showing you here were infected with KPC-producing Klebsiella, and almost all of them compared to polymyxins as the prior standard of therapy. So keep that in mind as we move forward today. So we'll start with one important case, and this is a case that we manage at the University of Pittsburgh, where I practice. And it was one of the first patients we treated with ceftazidime avibactam. And it really challenged our thought process in a number of ways that I'll explain to you. This was a 66-year-old female with COPD. She had a prior double lung transplant done through a clamshell procedure, which you can see on the right-hand side of the screen. And after transplantation, she had several complications. I've listed them on the slide for you, but including Clostridium difficile, recurrent infections with multi-drug resistant gram-negative infections. She had Candida albicans infection at the clamshell incision site. She had multiple rejection episodes, and including CMV proctitis and viremia. So a very complicated patient that now comes arriving at our door that again was quite sick. So she came to our hospital with new onset fevers and shortness of breath. And you can see her imaging on the screen there. Nothing good about the way that image looks. And unfortunately, quickly after she was admitted to our hospital, she was rapidly transferred to the intensive care unit. She was in septic shock. She was intubated and sedated for further management. Now, in dealing with a patient like this, of course, your differential diagnosis is very, very broad. This could be caused by any number of things, including viral causes, invasive mold infections, and other opportunistic pathogens that you see listed on the screen. But obviously, we're here to talk about gram-negatives and ceftazidime avibactam, so let's focus on the bacterial pneumonia part of this for a moment. And what we found is we initially started her on meropenem and ciprofloxacin. Now, I'll remind you, this was about the year 2016. We didn't have a lot of experience with ceftazidime avibactam, and so we started a carbapenem and added a second gram-negative agent given her prior microbiologic history. Unfortunately, she didn't respond whatsoever. She had rising vasopressor requirements, was requiring high rates of oxygen through the ventilator, and she was eventually initiated on continuous renal replacement therapy. A bronchoscopy that was done on admission was now growing 100,000 colony-forming units of gram-negative rods, and other diagnostic workup for fungal or opportunistic infections was negative at this point. Day 3, we eventually identified Klebsiella pneumoniae, and here's the resulting susceptibility that we found. And you can see on here that this was indeed a CRE by the meropenem resistance and susceptible to both ceftazidime avibactam and meropenem vaborbactam. Now, in 2016, all our microbiology lab was doing at that time was using a modified carbapenem inactivation method to tell us this was a carbapenemase producer. But based on our local epidemiology, we had a pretty good sense this was due to a KPC producing Klebsiella. So this was one of the first cases reported in this initial report that we published several years ago now of the first 77 patients like this that we treated with ceftazidime avibactam. Now, my institution, when we see carbapenem-resistant Klebsiella, the vast majority still are due to KPC, and you can see in this report, 93% of Klebsiella indeed harbored KPC. All of them were susceptible to ceftazidime avibactam at baseline, and most patients in this report, 69%, received ceftazidime avibactam as monotherapy. Now, when we looked at the outcomes of patients, we were quite encouraged that survival rates were 81%, thinking back to what they were before we had ceftazidime avibactam, that was tremendous. And clinical success rates, more than half of patients not only survived 30 days, but they improved the signs and symptoms of their infection. But as we dug deeper into the data, there were some important stories to be told. And this is one of them. When we looked across the rates of clinical cure by infection type, see bloodstream infection or intra-abdominal infections, pneumonia, urinary tract infections here, we saw lower rates of response for pneumonia specifically. We wondered, why were patients not responding? Was it they were more critically ill, or was there something else going on with the way we were dosing this particular antibiotic? If you fast forward a few years, we now know that ceftazidime avibactam, both components of that antibiotic, ceftazidime and avibactam, concentrate in the epithelial lining fluid at about 30% of the concentrations received in the serum. And in fact, we found that pneumonia and a common denominator with the patient I just presented to you, continuous renal replacement therapy, were independent predictors of clinical failure in our very early experience. And so when we looked across then not only patients who were failing, but patients who went on to develop resistance to ceftazidime avibactam, we saw some common themes emerging. These are now the first 13 patients that we saw develop resistance to ceftazidime avibactam. And you can see they developed resistance over various courses of treatment, but most of these patients had pneumonia. And in fact, a lot of them received renal replacement therapy. Now, when ceftazidime avibactam was first marketed in the United States, there was zero guidance on how to dose this antibiotic for continuous renal replacement therapy. And you guys know at your hospital, when you don't have guidance, what you do is you make educated guesses. Where our educated guesses were all over the place. You can see here in the red font that dosing ranged anywhere from 0.94 grams every 24 hours to 2.5 grams every 8 hours for patients on continuous renal replacement therapy. And almost certainly we were underdosing patients that were requiring continuous renal replacement therapy in the early days of ceftazidime avibactam, and almost assuredly that precipitated resistance in many of these patients. But if you look across this entire continuum of risk factors that I'm showing you here, it begs the question, are we achieving the right exposures in our most critically ill patients with ceftazidime avibactam? So we went back to some of the very early literature, and I'm going to show you some data from 2012 where avibactam was previously known as NLX 104. So it's going to look a bit weird on the screen here. But we asked the question, how much avibactam do you need to actually suppress resistance? And do we achieve those levels in the lungs of our critically ill patients? Well, this is a series of hollow fiber infection models that ran continuous infusions of ceftaroline with continuous infusions of avibactam. And they looked at dose ranges of increasing increments of avibactam from 2 milligrams per liter to 4 to 6 milligrams per liter. And what you can see is as you increase the avibactam exposures, you get extended killing, but eventually you get regrowth after 7 or 8 days in a hollow fiber infection model. And it wasn't until you reached a concentration of 8 milligrams per liter of avibactam that you eventually were able to kill the organism and suppress resistance amplification. And if you go even further to 10 or 12 milligrams per liter, now you suppress both the wild type and the resistant populations by the dark and white circles. So the short answer here is you need a lot of avibactam to suppress the resistance in a hollow fiber infection model. So do we achieve those levels of exposure? Again, at least 8 milligrams per liter as a continuous infusion in this model. Do we achieve those in patients? Well, if you look at the epithelial lining fluid concentrations of both ceftazidime and avibactam, we reach peak levels or maximum concentrations of avibactam of around 5. We need 8 to suppress resistance. So this should tell you that pneumonia certainly is a risk factor for both treatment failure and the emergence of resistance if we don't dose this antibiotic appropriately. And of course, in the early phases, we didn't know better and we weren't dosing it appropriately. But now we know better and we can improve upon these practices. And so let's ask the broad question then, why is it so difficult to appropriately dose antibiotics in the setting of pneumonia? Well, there's a number of factors that we think about in terms of designing the best dosing regimen. Number one is we know that there's limited penetration into the epithelial lining fluid, as I've just shown you with ceftazidime avibactam. Some antibiotics are inactivated by pulmonary surfactants. But also importantly, when we see multi-drug resistant pathogens, usually the reservoir is the respiratory tract. And the data I'm showing you on the screen shows just among common pathogens, and you're looking at ceftazidime avibactam MICs for Pseudomonas, you see that the MICs are increased for patients with ventilator-associated pneumonia compared to patients who are not ventilated. So the setting is perfect. It creates the perfect storm of very sick patients, limited penetration of antibiotics against resistant pathogens. So I would argue to you that one of the places we need to be very aggressive with our antibiotic dosing is in the setting of pneumonia in critically ill patients because of this other point at the bottom. These are also patients that rapidly change how drugs are processed in their body. They have very large volumes of distribution, their renal function changes rapidly. These are all factors that we can't control individually, but we can control perhaps how we dose some antibiotics. So this is another example of why ventilator-associated pneumonia is a setting where I think you should be more aggressive. This is looking at the probability of achieving the targets you see in the yellow boxes of both ceftazidime avibactam across different infection types. Again, intra-abdominal infections, urinary tract infections, and I've highlighted for you in the red box ventilator-associated pneumonia. You'll appreciate from the slide that the exposures, despite giving the same dose of antibiotics to all of these patients with various infection types, the exposures are lower in the setting of ventilator-associated pneumonia. So again, giving the same dose doesn't necessarily equate to getting the same exposure. Now, what if you wanted to have an even higher exposure? Maybe you really like the hollow fiber data I just showed you. You said, I got to reach 8 milligrams per liter of avibactam to suppress resistance. Well, if you want to do that, and I encourage you to do that, you have to now start thinking about extended infusion of ceftazidime avibactam, or even a common theme that I'm going to introduce you during this seminar is continuous infusion of ceftazidime avibactam to reach some of these higher pharmacodynamic targets. And we know actually that we have clinical evidence to suggest that this works. This is a very large observational study done from Italy, 577 patients. Most of the patients in this study had bloodstream infections or pneumonia, and there's some very important observations. Number one, when we inappropriately adjusted the dose for renal impairment, it was associated with worse outcomes. Ceftazidime avibactam is remarkably safe to give to patients. If you're ever between two doses, you should always be picking the higher dose. And when we were too quick to adjust the dose for patients in this study, they had worse outcomes. Combination therapy did not improve outcomes whatsoever, so adding a second antibiotic, whether it be fosfomycin or colistin or aminoglycosides, didn't improve outcomes at all. But what did improve outcomes is extending the infusion of ceftazidime avibactam to at least 3 hours. And you can see on the Kaplan-Meier graph this had a statistically significant impact on mortality for patients with KPC-producing Klebsiella infections. So I would argue that we should all be giving ceftazidime avibactam over at least an extended infusion, particularly for patients with pneumonia, based on the data I've just shown you. Now, what about continuous renal replacement therapy? How in the heck are we supposed to dose an antibiotic when we don't know what the exposures are? Well, we did an observational study a number of years ago, and I'll share with you some of these data. This was the first study, pharmacokinetic study done in ICU patients receiving continuous renal replacement therapy. And what we found is that we actually started giving patients the full dose of ceftazidime avibactam, 2.5 grams intravenously every 8 hours. And what we found in doing that is the exposures, even for patients with really good baseline renal function, were very similar to patients with continuous renal replacement therapy that we gave the full dose to. And so it's become now the standard practice at our hospital to dose ceftazidime avibactam at 2.5 grams every 8 hours for patients on continuous renal replacement therapy, which is contrary to what many of our hospital guidelines will say. They'll say dose for a creatinine clearance of 30 milliliters per minute. But we don't do that for ceftazidime avibactam because we know how important the exposures are. Now, if you think that we're aggressive with ceftazidime avibactam exposures, wait till you see this next study. This was just published a few weeks ago, actually at the end of 2023. This is a study of 8 patients on continuous venous hemodialysis. All patients in this study had difficult to treat gram-negative infections. And the way they dosed ceftazidime avibactam here is very interesting. They gave everybody a 2.5 gram loading dose, and immediately after that loading dose, they started a continuous infusion of ceftazidime avibactam. What they did next is quite cool. Many of us don't have the capability of doing this, but they did real-time therapeutic drug monitoring. We said, we're going to start the highest dose of ceftazidime avibactam we can. We'll monitor the blood levels of this drug in our patients, and we'll try to achieve very aggressive targets for both ceftazidime and avibactam. And so not only were they giving aggressive doses, but the rate of clearance through CRRT was very high. Many of us don't dialyze patients quite this rapidly, but they were very aggressive with renal clearance. But importantly, every single patient in this study achieved these high pharmacodynamic exposures. And in fact, for many patients, because they had the ability to measure the drug levels, they actually decreased the dose to 1.25 grams every 8 hours. The mean concentrations of both ceftazidime and avibactam you see listed here. And again, we don't need to make this so much about pharmacokinetics, but look at those avibactam exposures. Now you have a steady state concentration of 22 milligrams per liter, far above the levels we know to not only reach efficacy, but also to suppress the emergence of resistance. Now, notably, in our experience and the experience I'm showing you here, there was no adverse events identified for giving ceftazidime avibactam at high exposures. This should be an assurance to many of us, even though these are small numbers, that this is a very safe medication that should be optimized through either extended or continuous infusions. Okay, so let's talk about another site of infection where it's typically and notoriously hard to get antibiotics to, and that's the central nervous system. This is a case that was graciously provided by Herman. It's a 54-year-old diabetic Hispanic male with a past medical history for diabetes. He was admitted to the emergency department with a 2-week history of intermittent fevers, bilateral ear pain, severe headache, and an unsteady gait. He was originally from Ecuador, but had lived in the United States for the last 5 years and had no travel history. On admission, you can see the patient was febrile, but otherwise hemodynamically stable. And he was ill-appearing but conscious and really no altered mental status and had no neck stiffness at baseline. An otoscopic exam showed that he had left opaque tympanic membrane with a loss of light reflex, but no discharge coming from the ears at all. The right ear was unremarkable, no mastoid tenderness, examination of the sinuses, his mouth and throat were otherwise unremarkable. Lung exam was clear, no focal neurological deficits, and his laboratory values really showed a significant left shift with a high white blood cell count, but otherwise this elevated serum lactate and other labs that you see listed there. So not surprisingly then, with the possibility for a CNS infection, a lumbar puncture was performed and resulted in immediate relief of the patient's headache. And you can see there, based on the fluid analysis, that we'd have a high suspicion for bacterial meningitis or bacterial central nervous system infection. And in fact, the gram stain was showing gram-negative bacilli growing on the gram stain. Later, the patient was initially started on empiric intravenous antibiotics with ceftriaxone, vancomycin, ampicillin, and high-dose steroids with dexamethasone. And you can see the CT here showed right frontal sinus inflammatory changes, but the meningitis encephalitis panel was otherwise negative. So, not surprisingly, knowing the theme today, what eventually grew in those CSF cultures was Klebsiella pneumoniae. And you can see here that based on the gene expert, we identified KPC that was susceptible to ceftazidime avibactam. This is a question that I've been asked for the last 5 to 6 years, is can you use ceftazidime avibactam effectively for central nervous system infections? And the answer I've always given is I don't know. We don't have human pharmacokinetic data to tell us what the right answer is. And so I'll ask the same question, but now inform it with some recently published data. And I think before I show you some of the data, it's important to remember all of the barriers that we have to achieving therapeutic concentrations in the CNS. Both the molecule size, the lipophilicity of the molecules, whether there's high extension of inflammation, active transport mechanisms, are you trying to treat an antibiotic that's highly protein bound, etc. These are some fantastic review articles. If you're interested in learning more about this, I'd encourage you to take a look at these 2 articles. But importantly, as it relates to ceftazidime avibactam, we have no idea what the right exposure in the CNS should be. PK/PD targets are generally developed based on serum exposures, not exposures in the CNS specifically. We have very limited human data. What animal model data suggests is that if you give standard humanized doses of ceftazidime avibactam, somewhere between 18 to 38% of avibactam reach the CNS. And these are the data that we had to make clinical decisions up until the last few months. Because this report and the report I'll show you next were just published. The first report identifies 3 patients that were identified in this case series. You can see all of them actually had bacterial meningitis due to either KPC, Klebsiella enterobacter, or a difficult to treat Pseudomonas. All of the patients received the standard dose of ceftazidime avibactam, the first patient through an extended infusion. And simultaneous samples from both the serum and the CSF were obtained in all 3 patients. So this gives us a pretty good idea of the penetration ratio of avibactam. And in fact, what they find here is that the penetration ratio of avibactam is very high, around 30% in all 3 of these patients. much higher than we would have forecasted based on the animal model, and much higher than we would have guessed initially. Now, importantly, both ceftazidime and avibactam achieved their pharmacodynamic targets in the central nervous system, and all three of these patients had a positive clinical outcome resulting in clinical and microbiologic cure. These are the first data that we've had to suggest that ceftazidime avibactam is highly effective and therapeutic in central nervous system infections. But now we have even more data. Just published, there's another case series out of China. This one includes 7 patients, very similar in terms of patient demographics. They all had bacterial meningitis due to difficult to treat pathogens, and all 7 of these patients improved with the use of ceftazidime avibactam at standard doses over a 2-hour infusion. Now, only 3 patients here had their CSF sampled, but they showed even higher penetration ratios, upwards of 50% for avibactam when given at standard doses. So not surprisingly then, the PK/PD targets were achieved for all 7 patients. So we can now have some evidence to suggest for your patients that have severe CNS infections, ceftazidime avibactam is an antibiotic that can reach therapeutic concentrations at this typically hard to reach site. Okay, I want to change gears now a little bit and talk about what I often consider to be the elephant in the room. Globally, when we look at the press or popular media, we talk about hospital superbugs or NDM and KPCs, but almost all of our hospitals deal with a very severe Pseudomonas problem. And Pseudomonas aeruginosa is certainly in the United States one of the most problematic pathogens that we've had to deal with in the last several years. And so I want to show you a case from my hospital that's a very common case for us. This is a 67-year-old man with a history of nasopharyngeal squamous cell carcinoma. He's had prior chemotherapy and several debulking procedures. He has chronic respiratory failure requiring a tracheostomy, end-stage renal disease requiring hemodialysis, and he was found to have acute onset shortness of breath, increasing ventilator requirements, fevers, and leukocytosis. And unfortunately, he was started on vasopressors. Laboratory values remarkable for leukocytosis and high oxygen requirements, and his chest x-ray was consistent with bacterial pneumonia. Now, this patient we knew very well in our prior experience, and he had many prior positive cultures. The most recent one prior to this presentation we have listed here, which shows a multi-drug resistant Pseudomonas that was susceptible to both ceftazidime avibactam and ceftolozane tazobactam. Now, in Latin America, it's a question of which of these 2 antibiotics will you be picking, and it's the same question in North America. Is there a difference between when we should be picking ceftazidime avibactam compared to ceftolozane tazobactam if both of them are available to you for a Pseudomonas like this? Well, the IDSA guidance, as Dr. Tama pointed out, suggests that these antibiotics are equally effective, as is imipenem relebactam. Again, combination therapy is not recommended. Don't give inhaled antibiotics. And the risk for treatment emergent resistance might actually be higher with ceftolozane tazobactam. AskMed takes a similar approach, but they only recommend ceftolozane tazobactam for the very simple reason there's not much data for ceftazidime avibactam for multi-drug resistant Pseudomonas. But we do have real-world data for ceftolozane tazobactam, and this is the major take-home from those real-world data, is that like we have seen with KPC in the past, when you use novel beta-lactams that are targeted towards resistant pathogens, and you compare the outcomes of patients who were treated with prior antibiotics like colistin or aminoglycosides, you see significantly improved rates of clinical cure and much less toxicity. And that's the take-home message from this paper that compared ceftolozane tazobactam to polymyxin or aminoglycoside-based regimens for Pseudomonas. But then in the year 2020, many of you recall ceftolozane tazobactam was not available to us. So the only antibiotic that we had real-world experience for multi-drug resistant Pseudomonas was not available. It allowed many of us to think again outside the box, what are we going to do to best manage these patients that have severe Pseudomonas infections? So let me contrast for you very briefly the differences between ceftolozane tazobactam and ceftazidime avibactam. Both of these molecules start with the core structure of ceftazidime. The difference, of course, with ceftolozane is it has a unique R2 side chain, and that R2 side chain does a number of things that help the stability of the molecule, both against AMP-C hydrolysis, but it increases the affinity for penicillin binding proteins, and make the organism, the antibiotic much less likely to be effluxed out of the cell. Now, it's also important to note here that tazobactam really isn't bringing anything to the party. They're kind of the plus one that didn't bring a side dish, because tazobactam's really not offering anything to suppress beta-lactamases in the setting of Pseudomonas. Now, in contrast to that, of course, we know avibactam is a very broad beta-lactamase inhibitor. And so by adding a beta-lactamase inhibitor, now we have much better activity for Pseudomonas that produce beta-lactamases, whether that be ESBL enzymes or certainly KPC, and we see a reduction in both the MIC50s and MIC90s. Now, what's equally important for you to know at your local institution is which of these two antibiotics has higher rates of susceptibility locally. Now, if you're at an institution that sees a lot of KPC producing Pseudomonas, the likely answer is you have much higher rates of susceptibility to ceftazidime avibactam. If you're at an institution that sees a lot of VIM producing Pseudomonas, maybe both are similar because neither are individually active against metallo-beta-lactamase producing Pseudomonas. But you absolutely, to make this clinical decision, need to know which of the two antibiotics should be preferred locally. Now, if we look into the randomized clinical trials that have been done for both ceftazidime avibactam and ceftolozane tazobactam, really all we've learned from these trials is that both of them are non-inferior to a non-optimized dose of meropenem 1 gram every 8 hours. Isn't that a bummer? Because that doesn't answer the question that we have. Are they equally effective compared to each other, and are they effective for multi-drug resistant Pseudomonas? And not surprisingly, in phase 3 trials, we generally don't enroll a lot of patients with multi-drug resistant pathogens. We tend to enroll healthier patients with more susceptible pathogens. So both antibiotics were shown to be non-inferior to meropenem, but doesn't answer the question of what we really want to know: are they equally effective for multi-drug resistant Pseudomonas? Now, last year, this study was published out of Saudi Arabia, which is the first study that's compared ceftazidime avibactam and ceftolozane tazobactam for multi-drug resistant Pseudomonas. By a non-matched analysis, they ended up with 100 patients exactly in each arm. Either they're really lucky or they stopped enrollment at 100 to make the numbers look good. But this was a multi-center study done in 6 hospitals in Saudi Arabia. They included patients that had multi-drug resistant Pseudomonas infections treated with either antibiotic for at least 48 hours. And they defined clinical cure as a resolution of signs and symptoms of infection without the need to change antibiotics for toxicity or resistance. And you can see in the graph that actually numerically the numbers are very similar rates of clinical cure, very similar rates of mortality and recurrent infections. So can we conclude from this single observational study that both ceftazidime avibactam and ceftolozane tazobactam are equally effective? Well, of course, you know me well by now. The answer is not always as easy as just saying yes, because there's a number of limitations to this study, one of which I think is really important for Latin America. The local epidemiology of Pseudomonas in the Middle East is very different than what it is in North America or other parts of the world, where carbapenemases like GES, for instance, would favor treatment with ceftazidime avibactam and not ceftolozane tazobactam. And unfortunately, less than half of the isolates from patients included in this study were actually tested for susceptibility. We don't even know if the patients that received these antibiotics were infected with isolates susceptible to the antibiotic they received. We also know that antibiotic dosing was on the low side for ceftolozane tazobactam. Many of the patients received suboptimal doses of ceftolozane tazobactam, and the majority of those patients who received low doses actually failed their antibiotic regimen. And then polymicrobial infections and combination therapy was most common in the ceftolozane tazobactam arm. And you'll know from real-world observational studies, when you see signals like this, more common polymicrobial infections, more common combination therapy, usually what that's a clue of is higher severity of illness in one group versus another based on how patients were managed. And in fact, 47% of patients... Do we need to evacuate? Oh, okay, it's off. Terrific. I think they were telling me my presentation's on fire. It's really good. All right. So there's a number of limitations to this study, and mixed infections were also common. So I think we have to be very, very careful of drawing conclusions from observational studies. And you see a number of reasons why you can't just judge a book by its cover in the setting of this one study. And of course, we know that the molecular epidemiology, as Dr. Tama showed us yesterday, varies significantly for carbapenem-resistant Pseudomonas versus Latin America, North America, and others. Okay, so what is our proposed solution to all these problems I'm throwing at you? Well, we recently designed this study we call a cactus study. This is an observational study that's done at 29 centers in the United States that's led by myself and my colleague, Dr. Jason Pogue. And what we tried to do is answer the very question that I've proposed. Are ceftolozane tazobactam and ceftazidime avibactam equally effective for multi-drug resistant Pseudomonas? And what we tried to do is we matched patients by things we knew would mediate outcomes. So we matched patients within each hospital, we matched them by the severity of illness, we matched them by the infection type, and we matched them by the time to treatment initiation, or how quickly it took to start treatment with each of these two antibiotics. Now, the other important part of this particular study is we only included patients with bacteremia and pneumonia. And why did we do that? Well, inherently, we know the outcomes of patients with urinary tract infections or even intra-abdominal infections that are due to source control are very different than critically ill patients with pneumonia and bacteremia. So we only enrolled the sickest patients we could find across these 29 centers. And here's what we found. This is a preliminary analysis of the first 153 matched pairs. These are unpublished data, so please don't put them on Twitter. But what I will say is that the matching worked remarkably well. Look at these two groups. They're well balanced in terms of baseline demographics, in terms of immunocompromising conditions, Charlson scores, and even where they came from. So the matching worked really, really well in this particular study. That is particularly true when you look at severity of illness. Not only was severity of illness well matched between patients who received ceftolozane tazobactam or ceftazidime avibactam, but you can also appreciate from this slide how sick these patients were that were enrolled in this study. 82% of patients were in the ICU at the time of treatment initiation, and 74% of them were receiving mechanical ventilation. Again, one of our goals with real-world observational studies is to be able to study the types of patients we see in clinical practice, not necessarily the types of patients that are enrolled in randomized clinical trials, but those patients you're encountering in your day-to-day practice. And I think this study does a good job of that. So in terms of treatment characteristics, what we found, again, the matching worked well. The median time to the initiation of treatment was well balanced between the two groups. But we did see some minor differences in terms of receipt of prolonged infusion, which was more common with ceftolozane tazobactam, and suboptimal dosing was also slightly more common with ceftolozane tazobactam, but otherwise median durations of therapy and receipt of combination therapy were equivalent in the two groups. So for the most part, our retrospective matching worked particularly well. And here's what we found. Much like the Saudi Arabia experience, we found no difference in clinical outcomes across all of these endpoints, whether it be clinical success, 30-day mortality, recurrent infections, or the emergence of resistance within 90 days. So this gives us now some of the first observational data to suggest, yes, ceftazidime avibactam is as good as ceftolozane tazobactam for multi-drug resistant Pseudomonas. And of course, that's what some of our preliminary conclusions are. Now, we have just finished enrollment for this study, and we'll be providing the full results at ECCMID in April next month. But I anticipate we'll see very similar observations, is that similar efficacy between these two antibiotics. But importantly, to know for your populations, this largely includes patients that did not have carbapenemase-producing Pseudomonas. So if you can identify isolates at your institution that don't produce carbapenemases, you should feel confident using either ceftazidime avibactam or ceftolozane tazobactam for those patients. Okay, last case for the day is the gorilla in the room, if we've already talked about the elephant in the room, and that's NDM. This is another patient managed at the University of Pittsburgh. It was a 48-year-old male with a history of alcoholic cirrhosis. He underwent a living donor liver transplant. His donor was his daughter. Under basiliximab induction. You see his immunosuppressive regimen and prophylaxis regimen there. And importantly, this patient was from India. He had immigrated to the United States 25 years prior to presentation. But he still visited India somewhat periodically, his last visit at least 1 year prior to transplant. And his daughter, who was the donor again, had last visited India 4 years prior. His transplant procedure went relatively well. There was no complications. And in fact, he was discharged out of the ICU within just a couple of days of receiving a liver transplant. But unfortunately, on postoperative day number 5, he developed a low-grade fever, which prompted us to empirically start vancomycin and piperacillin tazobactam. And by postoperative day 7, we knew his cultures were growing E. coli. We stopped the vancomycin and left him on piperacillin tazobactam. But then on postoperative day 8, these were identified as meropenem resistant. Now, this is where the local epidemiology story kind of falls apart, because we had incorrectly presumed a meropenem resistant E. coli would be due to KPC at our institution. But that was not the case here. So he was started on meropenem vaborbactam, and it wasn't until 2 days later when we got this evidence. And this susceptibility profile is a very important clue for us of the potential for metallo-beta-lactamase producing organism when we see high levels of ceftazidime avibactam resistance. Now, we did the subsequent steps that we know to do now is we tested the organism for carbapenemase production and indeed found NDM. It produced an NDM1 variant on a plasmid. And then we did the strip overlay method. I don't know if this is Herman's favorite method or not, but it's the one that we used. And what we found is that the ceftazidime avibactam plus ace-trionam MIC was 8. And we said, well, what are we going to do with this? Well, we didn't want to treat him with aminoglycosides, and so we ended up initiating the combination of ceftazidime avibactam plus ace-trionam. And so we know now that this is a very effective combination for NDM-producing Enterobacteriales, and the IDSA guidance suggests that this should be a frontline regimen for NDM. Now, importantly, I'm going to talk a lot about dosing over the next few slides. So if you really love pharmacokinetics, you're in the right spot. If you really don't love pharmacokinetics, I'm going to summarize the high-level points here in just a minute. But importantly, what the IDSA recommends is very aggressive dosing of ceftazidime avibactam plus ace-trionam. You see the standard dose of ceftazidime avibactam plus 2 grams every 6 hours of ace-trionam, both over a 3-hour infusion. So is that the right dose for NDM? Well, we know we have some clinical data from Italy that suggests that this combination works better than other active antibiotics, and we've talked about this at other seminars, so I won't go over the same data, but this group just published an updated analysis out of Italy. This is another single-center study that was done in Pisa, Italy by Marco Falconi's group. This is just published in Clinical Infectious Diseases, and now it includes 343 patients with metallo-beta-lactamase-producing infections. Most of those patients had bloodstream infections, and the vast majority received active antibiotics within 48 hours. So what did they find? Well, they compared a number of different treatment strategies in this study. And what they found is actually ceftazidime avibactam was statistically superior than colistin, something we certainly knew. But there's some other important factors here, is that colistin-based regimens did relatively poorly. These are 30-day mortality rates. 50% of patients that received colistin died within 30 days. Even the subgroup that received cefiderocol had higher mortality than ceftazidime avibactam versus ace-trionam. Now, these are small numbers, and this is a non-matched analysis. And so what the authors did is they did a Cox proportional hazards model to try to control for some of the baseline differences between groups. And when they did that, they found that indeed the combination of ceftazidime avibactam plus ace-trionam was the best antibiotic combination when you controlled for other factors like severity of illness or advanced age. And what they report in their study is that they give ceftazidime avibactam and ace-trionam both every 8 hours over a 2-hour infusion. But they don't report any MIC data, so we don't have a great sense if this is the right dose for all patients in this study. But these are the now most recent data that we have to support the combination for NDM producing Enterobacteriales. But is it the right dose? There's been a number of studies done now that have looked into different ways we can dose ceftazidime avibactam plus ace-trionam. This is one that's been also recently published by Tom Lodis and colleagues that looked at a series of isolates in a hollow fiber infection model. And what you can see from the one example I'm showing you here is that the dose that we just saw used in Italy quite commonly in the green here, ceftazidime avibactam and ace-trionam every 2 hours, did result in some initial bacterial suppression, but they noticed regrowth. after a number of days. And they were able to suppress to some extent this regrowth by giving continuous infusions of both ceftazidime, avibactam, and aztreonam. So is this enough evidence to say, well, maybe we should be giving continuous infusions to our patients? Well, not quite yet. But I think if you look across all of the isolates studied in this particular paper, you'll see that in general, continuous infusion was more effective than giving intermittent bolus dosing. Now, other things that we learned from this paper is that if you can avoid it, you would never want to stagger the doses of ceftazidime, avibactam, and aztreonam. That was always suboptimal in this particular paper. So if you cannot do a continuous infusion, you at very minimum want to infuse these antibiotics concomitantly or at the same time. But if you can do a continuous infusion, there was some benefit in a hollow fiber infection model. So what is the right dose? And this is the last thing I'm hoping to leave you with today. This is another paper that was just published. This summarizes all of the available PK/PD data for aztreonam avibactam. It is the summary of how they came up with the right dose for aztreonam avibactam, which we expect to be available later this year in North America and hopefully very soon in South America. So when you put all of the data together, what do you find? Well, here's the key takeaways. Number one, and very, very importantly, you need more avibactam to rescue aztreonam than you do ceftazidime. And we see this measured here by a pharmacodynamic target known as free time above a critical threshold. For ceftazidime, that threshold is 1 milligram per liter. You want at least avibactam above that threshold for 50% of the time. It is 2.5 times higher for aztreonam, meaning if you're using aztreonam and avibactam together for NDM, you need more avibactam. So the standard dose that we give with ceftazidime avibactam was never intended to do what we want to do for NDM. It was intended to treat KPC. But if you're using aztreonam avibactam together, number one, you must know you need more avibactam to be effective. Secondly, the renal clearance of aztreonam and avibactam is not well matched. In fact, aztreonam undergoes non-renal elimination about 20% of the active drug. And in fact, if you look at many of your hospital institution renal dosing guidelines, you'll see we do something different for ceftazidime, avibactam, and aztreonam. We typically don't adjust the dose of aztreonam until the creatinine clearance is less than 30, but we adjust it for ceftazidime, avibactam when the creatinine clearance is less than 50. What happens as a result of this mismatched renal elimination is you end up with prolonged exposures of suboptimal dosing. And so to overcome that, we have to think creatively with pharmacodynamics, and I'll show you that in just a second. Third, and most importantly, we have now become accustomed to using this combination for things that it was probably never intended to do. The pharmacodynamic target for Enterobacteriales suggests we need at least 60% time above MIC for aztreonam. I promise you this is the last pharmacokinetic nerdy stuff we're going to talk about. But there is not a target for Pseudomonas. You will not find an aztreonam avibactam target for Pseudomonas in the literature. And we know based on other antibiotics that the target changes depending on what we're trying to treat. So can we use what we know about Enterobacteriales and apply it to Pseudomonas? Well, here is the conclusion of this paper that I mentioned, and this is the proposed dosing regimen for aztreonam avibactam. I want you to think about this dose relative to what many of you are doing at your local institution now. The proposed dose is a loading dose of 500 milligrams of aztreonam plus 167 milligrams of avibactam. The scientific rationale for loading doses is to get you to a therapeutic concentration faster. And so that's something that these investigators have identified as critically important for aztreonam avibactam. And immediately after that 30-minute loading dose, they start a maintenance dose of 1,500 milligrams of aztreonam and 500 milligrams of avibactam every 6 hours over a 3-hour infusion. So if you give an antibiotic every 6 hours and it's infused over 3 hours, you're essentially 3 hours in and 3 hours off. 3 hours in, 3 hours off. That's how they've decided to optimize the exposures of avibactam to reach those targets I just showed you. Now, if you compare that to what we currently do, if you take the standard dose in Italy, maybe the standard dose in Latin America, it does not achieve the probability of target attainment more than 90% for anything with an MIC above 4. Pharmacodynamically, it doesn't get there. It doesn't mean it's not going to work, but on a population level, you don't get there unless the MIC is less than or equal to 4. Now, most of the enterobacteriales we see clinically have very low MICs to Ace-Trinam avibactam. So you're definitely achieving these targets for enterobacteriales. But it begs the question whether you can achieve them for Pseudomonas that we know have higher MICs for Ace-Trinam avibactam. If you don't believe me, here's the evidence. When you look at observational surveillance data that looks at the MICs of Ace-Trinam alone versus Ace-Trinam avibactam against metallo-beta-lactamase producing Pseudomonas, you see here the MIC 90s are 32 and 64. You are able to decrease the MIC 90 by about 1 dilution. And if you said, okay, Ryan, I believe you, we need MICs less than 4. Well, across metallos, only about 16% of metallos have Ace-Trinam avibactam MICs less than 4. You said, okay, I'm gonna do what you said. I'm gonna give continuous infusion, and I'm gonna get up to MICs of 8. Well, now you can cover about 38% of metallo-beta-lactamase producing Pseudomonas. So it's important to know the limitations of these antibiotics now we're forced to give because we don't have other alternatives, but to know the limitations in terms of pharmacokinetics and pharmacodynamics, and know that we should be dosing aggressively if we're using this combination for Pseudomonas. Now, I am a glass half full kind of guy. I always like to leave on good news and good footing. And so I dug back to find any literature I could find for this combination for Pseudomonas, and I found this paper published in 2012. And what this paper did is they looked at 13 different Pseudomonas isolates. You can see many of these isolates did indeed harbor metallo-beta-lactamases, and they had various MICs to Ace-Trinam avibactam anywhere from 4 to 32. And they put them all into a neutropenic murine thigh infection model. Now, what they did is they simulated the exposures of Ace-Trinam 2 grams every 6 hours and 600 milligrams of avibactam every 6 hours. Both of those are higher than the proposed dose of Ace-Trinam avibactam that I just showed you. But when they simulated those exposures, this is what they found. I want you to pay attention to the black bars here. This is Ace-Trinam plus 600 milligrams of avibactam. Across these 13 isolates that have, again, MICs from 4 to 32, they saw fairly consistent log killing in a neutropenic thigh infection model. So this is where one of the great disconnects is. If you only relied on the in vitro PK/PD data, you'd feel pretty pessimistic about using Ace-Trinam avibactam for VIM or NDM producing Pseudomonas. But if you looked at some of this early animal model data, you might be encouraged to say maybe it's better in vivo than what we can achieve in vitro. And there are some preliminary evidence to suggest that. And what this paper suggests is you need to get at least 65% time above MIC to do that. All right, so let me wrap up with some kind of high-level take-home points from a lot of data that we've just gone through together. Number one, I think it is absolutely important to underscore the fact that ceftazidime avibactam has undeniably saved the lives of our patients. We know that factors that were historically associated with treatment failure included pneumonia and renal replacement therapy, and those are the two settings in which I would argue with you that we need to use higher doses, particularly extended infusions of at least 3 hours. We have clinical observational data to suggest that a 3-hour infusion results in lower mortality for our patients with KPC producing Klebsiella infections. And if you have a very sick patient on renal replacement therapy with pneumonia, you may even think about continuous infusions to achieve some of these higher targets that we've talked about. Secondly, and encouragingly, we've learned in a couple of recent papers that the penetration ratio of avibactam into the CNS is much higher than we thought. Now, it could be because of patients had a lot of inflammation and they had post-surgical meningitis, but it also shows us that a significant proportion of avibactam crosses the blood-brain barrier, and I do think absolutely ceftazidime avibactam is a viable option for CNS infections. Third, in the setting of multi-drug resistant Pseudomonas, we've learned through the Cactus study and the studies done in Saudi Arabia that ceftazidime avibactam demonstrates similar efficacy to ceftolozane tazobactam. And if you have a carbapenemase producing Pseudomonas and it produces either KPC or maybe a non-carbapenemase like ESBL, ceftazidime avibactam is absolutely going to be preferred in those settings because of its extended ability to inhibit beta-lactamases. Now, these studies do not include metallo-beta-lactamase producing Pseudomonas, And if you remember what we talked about metallo-beta-lactamase producers, ceftazidime-avibactam plus aztreonam is the frontline treatment. And for Enterobacteriales and even Stenotrophomonas, we can generally use standard doses to achieve our pharmacodynamic targets. But for Pseudomonas specifically, I would encourage us to think about at least extended infusion or maybe even continuous infusion to treat higher MICs. We have some animal model data to suggest that that's effective. The in vitro data suggests it's harder to achieve those targets, so we need to be more creative with our dosing regimens. So with all that information taken into account, I thank you so much for your time and attention. It's been a pleasure speaking today.
Ryan, that was a fantastic talk. It was, but now we have a lot of doubts about it. So if I treat, well, the problem would be like we have co-production with NDM and KPC. Let's start with Enterobacterialis. So that means that I would be okay with KPC using the standard dose, so 2.5 grams Q8 in a prolonged infusion of 3 hours, or the best would be continuous infusion. Plus, what if I have NDM plus Astronam? You're suggesting to use 2 grams Q6 of Astronam?
Yeah, so for NDM producing Enterobacteriales, there's really 2 ways you can get it to your right target. What the data suggests is if you use a prolonged infusion of at least 3 hours, you're going to achieve your target up to an MIC of 4. Okay. And most of our metallo-beta-lactamase producing Enterobacteriales have very low MICs, sometimes 0.25, 0.5. So you can feel confident with an extended infusion that you achieve those targets.
Okay.
Where we run into more area of uncertainty is when the MICs are higher. And this is what we typically see with Pseudomonas, where they may be 4, 8, or 16. And that's where really the continuous infusion approach is probably the preferred approach to achieve higher MICs.
So if my choice will be for Pseudomonas aeruginosa. So for Enterobacteriales, I don't need to increase the Astronam dose for NDMs in Enterobacteriales?
There's 2 ways to do it. You can give it over 2 grams every 8 hours over a 3-hour infusion, okay, or 2 grams every 6 hours as a standard 1 to 2 hour infusion, both of which will get you there.
Okay. And for Pseudomonas, would it be wise to increase the dose of ceftazidime-avibactam? Let's say go for Q6, and Astronam, if it has a beam, to go Q6, 2 grams?
I wish we had data for that, because I think that's probably the right answer, is actually giving both every 6 hours as opposed to every 8 hours. Now, the backwards way of doing that is, of course, the continuous infusion, and we have no safety data to know if you give that much ceftazidime-avibactam plus aztreonam if there's increased toxicity. So that would be the main reason not to. There's a phase 1 study that's looked at the pharmacokinetics of these, and they found the more aztreonam you give, the higher rates of liver transaminase elevation you see. But otherwise, we just don't have the safety data to recommend something like that.
But so there's any situation, clinical situation, will you give Astronam Q6 2 grams? When?
Yeah, I think when the MIC is elevated.
Okay.
You know.
So you keep the ceftazidime the same dose, prolonged infusion or continuous infusion,
yep,
but you add Astronam in Q6.
Yep.
That would be one.
And the reason for that is, you know, if you think about the pharmacodynamics, which I know gets a bit confusing, you need more avibactam to protect aztreonam, but you can also give more aztreonam. So the little bit you lose still achieves your target. So there's 2 backwards ways of doing it. You either give more avibactam or more aztreonam, but you need more of one of them.
Okay. And the last one, with the case of the CNS infection, would you give only ceftazidime-avibactam IV, or would you do intrathecal too?
Yeah, we have just the 10 cases that I've shown you. That's all that's been published in the literature. And none of those cases received intrathecal antibiotics.
Okay.
Many of them actually received other intravenous antibiotics in combination, but not commonly intrathecal. I'm not aware of ceftazidime-avibactam being given intrathecally. Okay. Now, of course, we can give colistin and aminoglycosides and other things that might sterilize the CNS that could be advantageous, but not ceftazidime-avibactam that I've seen.
Okay, and the last one before Wandita. When would you give a loading dose of ceftazidime-avibactam or Astronam? Loading dose and then prolonged infusion or continuous infusion?
Yeah, Pseudomonas I would.
You do both? Always.
I would give a loading dose of both over 30 minutes and then start a continuous infusion if I was designing the optimal regimen for Pseudomonas.
For Pseudomonas and for Enterobacterales with NDM too?
I think it's less necessary there because
Okay.
you get to your target much sooner.
Even though the patient has a septic shock?
Yeah, I mean, you're never wrong giving a loading dose because you get to your target sooner. It's just not as necessary for Enterobacteriales because the MICs are much lower.
Okay, perfect. Wanda?
Thank you, Ryan. Excellent talk. We have a problem with Acinetobacter baumannii, resistance to colistin or tigecyclina. So we are using now ampicillina sulbactam plus ceftazidime avibactam, like the same like durlobactam, durlobactam avibactam. In the low countries, we use ceftazidime avibactam, ampicillin. What do you think about it?
So this is actually very interesting. I'm glad you brought this up, Juanita. This strategy is being used in Latin America as well as parts of the Asia Pacific. And the reason for that is we've always thought avibactam doesn't inhibit OXAs like OXA23 or OXA24, for example. And it doesn't with good efficiency. Durlobactam is a much better inhibitor for those OXA enzymes. But avibactam is like a poor man's version of durlobactam. It inhibits a little bit, but if you give enough avibactam, it actually inhibits penicillin binding protein 2. It has some intrinsic PBP2 activity. Now, there are some new studies available that suggest that this strategy might be viable. And if you have no other alternatives, then I think, yeah, if you have no other alternatives, then you should try something like this. But it's because of the avibactam intrinsic activity against PBPs that it might work. And the same idea is you're using sulbactam for PBP1 and PBP3, and then avibactam for PBP2.
So thank you very much, Ryan. I have some micro type of questions. And my first one will be, what about those isolates with MICs close to the breakpoint? I mean, something that we do right now is that we perform AST, and when you have, less than or equal to 8, you prescribe Septasavi for a KPC or something. But what happens when you have these isolates close to 8, for example, not 1, not 2, or should we break it down to treatment according to MIC because you show different kind of PKPD targets?
Yeah. So, this is what's so interesting to me about ceftazidime avibactam is many of you in the audience will know avibactam was always intended to be an ESBL inhibitor. And through its development, it was found to actually inhibit KPCs pretty well. And now it's become one of our frontline treatment regimens for KPC. But some of the early preclinical data were never designed to treat KPC, and they certainly weren't designed to treat NDM in combination with ACE-TRINAM. And that's why I keep saying we have to think outside the box, because this antibiotic was developed to do something completely differently than what we're using it for now. And that's just the reality of it. So, the initial MIC breakpoint of less than or equal to 8 was largely based on Enterobacteriales that did not have KPC. And so I would say if you have higher MICs, that's where I would be more inclined to go to prolonged infusion approaches. And if it's KPC, I feel pretty comfortable that still over a 3-hour infusion, you can get to MICs of 8. If it's an NDM with an MIC of 8, then you need to be more aggressive.
So why do you think that increasing the dose of a resistant Acinetobacter baumannii, increasing the dose of ampicillin sulbactam will make a difference?
Yeah, so this is all about sulbactam, actually. There's lots of different pharmacodynamic targets for sulbactam of how much you need and how much time above MIC. But there's actually many major challenges with sulbactam. One of which, and Herman can attest to this, we don't routinely test correctly for sulbactam in many of our clinical microlabs. We either test a fixed ratio with ampicillin and sulbactam, or if you're in UCAST, you only test a fixed concentration of sulbactam. So many times we don't actually know the sulbactam MIC. And when you don't know the MIC specifically, that's where you want to treat for the highest MIC it could possibly be. So that's one reason to give more sulbactam. The other reason is what the preclinical data shows, and Dr. Tama showed this earlier yesterday, is that you need somewhere of at least 6 to 9 grams of sulbactam to reach these pharmacodynamic targets, even if the MIC is low. And so the only way to do that is to give non-traditional doses of ampicillin sulbactam. The IDSA guidance document actually suggests 9 grams every 8 hours as a continuous infusion. So again, keep in mind, much like even ceftazidime, avibactam, amsulbactam was developed a long time ago before we knew any of these
Antes de que
pharmacodynamics.
supiéramos estas reglas de
I
farmacología
think we just have to be more creative in what we're learning now.
creativos y lo que estamos aprendiendo ahora es que estos mix deben ser mucho más altos. Gracias, Ryan Shields. Con este tema de las dosis más altas con los mix. Bueno, me gustaría preguntarte sobre la selección de la resistencia. Eso ocurre cuando tenemos un reemplazo
So, what kind of signal
y neumonía. Entonces, ¿qué tipo de señales tienen que ver con estos factores de riesgo y la exposición?
Capture those
Cuenta para capturar esos mutantes, por ejemplo, con Capecilia para Septasavi. Bueno, como tú sabes, hermano, este es un desafío enorme para los microlaboratorios, porque muchas de las variantes que tienen Ceftazidime, Avibactam, prueban ser susceptibles a carbapenemases, y muchos de estos laboratorios hacen esta detección basados en la resistencia. Entonces, a menudo estos se clasifican como BLES, aún si tengan algo de variable de KPC. Lo que buscamos normalmente en nuestra institución es cuando hay una exposición anterior a esto con la resistencia que vimos, por ejemplo, en el caso de Klebsiella neumonía. Entonces, después de haberse estado expuestos los pacientes a esto, se identifica la Klebsiella, entonces nuestro radar se vuelve más exhaustivo para buscar si hay resistencia. En los artículos me parece que claramente estábamos dando dosis demasiado bajas a los pacientes y eso hacía que hubiera resistencia. Entonces, en la terapia de reemplazo renal continuo, vemos que lo estamos haciendo hoy en día distinto y eso es lo que ha representado la diferencia. Entonces, esto significa que el punto a llevar a casa es que cuando hay reemplazo renal, hay una falla renal, uno tiene que mantener la misma dosis de ceftazidime, avibactam más astronam o ceftazidime, avibactam. Sí, ciertamente, sí, en los casos de CRRT, esos trasplantes hay que hacerlo, y en los casos de diálisis cada vez somos más agresivos, más que lo que dice la etiqueta del producto, que dice hacerlo por 48 horas, y nosotros tratamos de hacerlo a diario para minimizar las exposiciones bajas. Entonces, esencialmente, la quimodiálisis hacemos también esto en los reemplazos renales. Y una última pregunta, no prometo, pero cuando miran las sugerencias que hay para KPC, meropanem, como avibactam, viene primero y luego ceftazidime, avibactam. Pero a través, o si yo pienso como una persona que hace la administración adecuada de administración, yo debería pensar en esto antes que meropenem, porque en el caso de pseudomonas yo tengo una mayor probabilidad de que haya resistencia con mero que probablemente con ceftazidina. O en teoría yo debería utilizar los carbapenemasas antes de utilizar ceftazidina o cefapin o lo que fuera. ¿Qué opinas? Yo creo que en el tema empírico tienes razón. Esto no va a ser mejor que peronoma para pseudomonas. Y si tu preocupación es eso con pseudomonas, entonces también tienes preocupaciones por algo como KPC, entonces avibactam va a ser su opción empírica. Pero una vez que usted haya identificado KPC, no hay datos de comparativos que nos digan cuál es mejor. Hay 3 estudios observacionales y ninguno muestra una diferencia significativa estadísticamente hablante. Cuando vemos que se selecciona en vez de merobactam, de nuevo, eso depende de las exposiciones prolongadas, porque si no se debería usar y intercambiarlos. Bueno, hablando de nuevo con la neumonía, algunas de las prácticas que se hacen es dando una terapia combinada, añadiendo meropenem para proteger que haya resistencia. Entonces, ¿qué piensa usted de la terapia combinada cuando es susceptible con un MIC bajo en vitro? Me gusta mucho esa combinación y la razón es porque probablemente previene la selección de las variantes de KPC que son hipersensibles a meropenem. Hemos visto un modelo que utilizan estas dos conjuntamente nos dan resistencia, pero no hay datos clínicos. Esto es más como un descubrimiento científico que se traduce en la práctica clínica. Entonces, en nuestros pacientes, nosotros tenemos el lujo de tener la disposición de todos estos antibióticos, de modo que si van a utilizar una combinación de ceftoxidina y avibactam, y su preocupación es la resistencia de pronto en el caso de neumonía o reemplazo renal, yo pensaría que una sola tema de combinar esto sería mero pena. Y tú darías 1 gramo cada tanto, 1 gramo cada 8 horas en el reemplazo renal, pero esos son en una población muy específica, porque la gente se la empieza a dar a todo el mundo, y yo sé que eso nos va a matar. Sí, tienen que ser pacientes muy bien seleccionados. Hemos hablado aquí de el programa PRO, y muchos de los que están aquí que trabajan en PRO no van a ser muy aficionados a este abordaje, pero me parece que hay una alta probabilidad de tener resistencia, especialmente en esos pacientes críticamente enfermos. Sí, un punto muy importante antes de irnos es que utilizar ceftaxidina y avibactam en la dosis correcta y durante el tiempo de exposición correcta, porque si lo hacemos así, vamos a tener menor probabilidad de tener una resistencia a APC. Sí, es tan notable que se sabe cuando inicialmente se descubrió lo que sabemos hoy en día, todo ha cambiado, tratando nuevos patrones de resistencia, hay otros targets, entonces no podemos seguir prescribiendo la misma dosis como lo hacíamos hace 10 años. Muchísimas gracias, qué charla tan interesante y espero verte muy a menudo en nuestras reuniones.
Próxima sesión, entonces muchísimas gracias a todos, un aplauso a Ryan y a Pfizer por tener a Ryan aquí. Muchas gracias.
Les pedimos el favor de retornar los equipos de traducción en la zona exterior a mano izquierda. Gracias.
Cuando tengas confirmado, que se haya repetido.